Thank you, Joe.
Thank you. Good morning, all. It's just gone afternoon here, but I believe it's morning for you. Thank you for that warm welcome. Yes, as Rod said, I have joined the team. I'm an infection prevention and control nurse consultant, and I'm working alongside Donna, and I look forward to working alongside you all. So thank you.
Thank you, Joe. I'll now hand over to Susan Liu, who will be presenting today's information session. So thank you, Susan.
Thank you, Rod. Before I start, Vanderith, just wanting to know whether translation is needed for this session, because just that will sort of guide me as to how quickly I can deliver my presentation.
Yeah, I think that maybe I can provide some translation after your speech, a little bit after each slide presentation. Yeah.
All right, so can you see my screen?
Yes.
Yes.
Okay, all right, so we can move on with this discussion. So my talk today is about antimicrobial consumption monitoring. I want to spend some time looking at the rationale for why we want to do AMC monitoring, and then look at the methods and the different metrics that are used in AMC. And then I think I want to sort of finish off by looking at how AMC data could be used in antimicrobial stewardship programs. I've been doing AMC, I suppose, being a mentor for the Fleming Fund for the past 5 years. So I've been working in this space now and training and coaching clinicians, pharmacists, doctors in establishing their AMC systems, not just in their hospital, but nationally. And when I worked in Vietnam, we were also doing that with the Social Security, the Vietnam Social Security. So it is a very relatively complex technical area to understand. So this is only an introduction, because working with the Fleming Fund Fellows, we actually had to deliver this training over a 6-month period, and that included data analysis as well as interpretation, and then looking at how to use the data for policy making, as well as for implementing antimicrobial stewardship in the hospital setting. So please bear with me. It is not an easy topic to sort of, train online. So just let me know, Vanderith, at the end of this session, whether any participants would like to have further training in this. So when we visit later in the year, we can certainly look at a workshop environment.
ចឹងសូមគោរពជំរាបសួរម្ដងទៀតគាត់ជា presenter គាត់ឈ្មោះ Susan Lu ហើយថ្ងៃនេះគាត់នឹងធ្វើបទបង្ហាញទាក់ទងជាមួយនឹងការតាមដានទៅលើបរិមាណនៃឱសថប្រឆាំងមេរោគការប្រើប្រាស់នៅឱសថការតាមដានការប្រើប្រាស់នៅបរិមាណនៃឱសថប្រឆាំងមេរោគហើយថ្ងៃនេះគាត់នឹង cover ទាក់ទងជាមួយនឹងនីតិវិធីដូចជា methodology ក៏ដូចជា metric ដែលធ្វើការវាស់វែងទៅលើ AMC ហ្នឹងហើយ Susan Lu នេះគឺគាត់មានបទពិសោធន៍ធ្វើការជាមួយ Fleming Fund ជាច្រើនឆ្នាំទាក់ទងជាមួយនឹងការបង្កើតនៅប្រព័ន្ធតាមដានបរិមាណឱសថប្រឆាំងមេរោគនឹងមិនត្រឹមតែនៅក្នុងមន្ទីរពេទ្យទេប៉ុន្តែជាលក្ខណៈថ្នាក់ជាតិទៀតហើយគាត់ធ្វើការនៅខាងវៀតណាមដែរទាក់ទងជាមួយនឹង AMC monitoring នឹងដូចគ្នាហើយគាត់ថាកិច្ចការងារ AMC នេះមិនមែនជាកិច្ចការងារងាយស្រួលទេគឺវាមានភាពស្មុគស្មាញជាពាក់ព័ន្ធគ្នាច្រើនអញ្ចឹងថ្ងៃនេះយើង cover លក្ខណៈ introduction ទេហើយឲ្យបានឲ្យលោកគ្រូអ្នកគ្រូបានយល់អំពីAMC monitoring and consumption នឹងអីចឹងទៅហើយគាត់ថាបើសិនជាលោកគ្រូអ្នកគ្រូចាប់អារម្មណ៍យើងនឹង មើលថាក្នុងករណីពេលដែលយើងមាន trip ទៅមកស្រុកខ្មែរអីយើងនឹងលើក topic នេះដើម្បីធ្វើការ discussion ឬក៏បង្ហាញជា training ឬក៏អីបានទៅតាមពេលវេលាដែលយើងយើងគិតថាលោកគ្រូអ្នកគ្រូចាប់អារម្មណ៍ឬក៏អីអញ្ចឹងណាហ្នឹងហើយ Thank you.
Thank you. Okay, so why do we want to measure AMC? So I want to start off. I know all of you have probably been involved. Before Professor Kim also mentioned that you've been doing the PPS in AMU, which is the looking at how appropriately antibiotics have been prescribed at your hospital. So AMC is surveillance should be part of the monitoring that you're doing to know how much of what antibiotics and where they're being used. So it is really the essential first question before we should, before looking at any sort of AMS interventions that you want to implement. And I just also want to add that it may become an obligation, and I think maybe Professor Kim can elaborate more on that, but I know that Cambodia, you released your new National Action Plan on AMR in February this year, and that AMC monitoring or AMC surveillance is actually going to be part of an overall suite of interventions that you want to implement in your country. And Professor Kim mentioned before that you haven't been doing AMC monitoring in your country. And when we visited in February to Cosamac Hospital as well as to Calmet Hospital, that was certainly the case. And I think Poland is online today and probably could say that he's done a little bit of that at Calmet, but certainly not at Cosamac Hospital. So you can see here that Cambodia is really not, AMC monitoring hasn't really happened in Cambodia. So you've been doing AMU monitoring, and I will go into the difference between the two in the next couple of slides. And then here you can see that you want to roll out AMC surveillance in selected hospitals, but the timeline is a little bit far ahead. So you're getting a little bit of training earlier than what is in your National Action Plan. Vanderus?
Suzanne, can you move a little bit to the previous slide?
Sorry?
Could you move to previous slide so I can say something? Okay, thank you so much. So អញ្ចឹងអ្វីដែលគាត់បានលើកឡើងហ្នឹងគាត់ថាហេតុអីបានយើងត្រូវមានធ្វើការវាស់វែងទៅលើការប្រើប្រាស់នៅបរិមាណអាសត់ប្រឆាំងមេរោគហ្នឹងអញ្ចឹងគាត់ថាដោយលោកគ្រូសាវូនគាត់បានលើកឡើង Professor សាវូនគាត់បានលើកឡើងអញ្ចឹងថាយើងមានជា AMS Technical Working Group ហើយយើងក៏បានមានជាកម្មវិធី AMS Program ផងដែរហើយការខាតនៃការធ្វើ AMC monitoring ហ្នឹងគឺជាមាន AMC surveillance ដែល AMC surveillance គឺជា part មួយនៃ AMC monitoring ហ្នឹងអញ្ចឹង AMC surveillance ហ្នឹងគេនឹងធ្វើដើម្បីឲ្យដឹងថាតើបរិមាណប្រមាណដែលយើងប្រើប្រាស់ហើយប្រើទៅកន្លែងណានេះគឺជា question ដែលយើងត្រូវរៀបចំឲ្យឆ្លើយនៅសំណួរទាំងអស់ហ្នឹងហើយនៅក្នុងប្រទេសយើងមានជា Multi-sectoral Action Plan សម្រាប់ AMR ដែររយៈពេលឆ្នាំ2025ដល់2029ដែលបាន endorse ក្នុងឆ្នាំខែ2ឆ្នាំ2000ថ្មីនេះដែរទេឆ្នាំ2026នេះហើយយើងក៏មានការតាមដានលក្ខណៈអន្តរជាតិដូចជា WHO កន្លះ AMC វិប្រាក់អីចឹងទៅ Could you move to another slide? Okay, so នៅក្នុង Multi-sectoral AMR Action Plan របស់យើងគឺយើងឃើញថានៅក្នុងនោះគេបង្ហាញលក្ខណៈជា matrix មួយដែលតាក់ទងជាមួយនឹង AMC consumption នៅក្នុង human health ហើយយើងឃើញថាប្រទេសយើងអត់ទាន់មាន AMC monitoring ទេ ដូចនៅក្នុងរូបភាពដែលបានបង្ហាញហ្នឹងអញ្ចឹងហើយនៅក្នុង plan របស់យើងទៀតនៅក្នុងMSAP ហ្នឹងគេបាននិយាយថាយើងនឹង roll out AMC surveillance ហ្នឹងទៅកាន់មន្ទីរពេទ្យទាំងអស់ហ្នឹងនៅក្នុងរយៈពេលឆ្នាំ2028 2029អញ្ចឹងយើងឃើញថាពេលវេលាហ្នឹងវានៅឆ្ងាយទៀតប៉ុន្តែការដែលយើងទទួលវគ្គ training ឲ្យបានកាន់តែលឿនកាន់តែល្អឬក៏កាន់តែច្រើនកាន់តែល្អអញ្ចឹងទៅបាទអញ្ចឹងអរគុណច្រើន thank you.
Okay, so what is the difference between AMC and AMU? You've been doing the AMU auditing or the PPS using the point prevalence survey methodology now. I think at COSMAC, I think you've done it 6 times. So they are it is derived from patient level data, and you're using the global PPS, likely the WHO global PPS, to collect your data, and that's at the patient level, whether antibiotics comply with prescribing complies with guidelines, whether it's been used appropriately. So it is qualitative in nature, and it is assessing clinical practice against treatment guidelines mainly. Whereas AMC is different. It is derived from aggregated data, so not at the patient level. And it is looking at volume. So you're looking at very large quantitative data sets. And from that, it provides a proxy estimate of antimicrobial usage. Now, what I want to also mention is that WHO has changed their terminology, and they call everything AMU now, which is antimicrobial use surveillance. And so AMC and AMU, which is still in your national action plan, you're still using consumption as AMC. So in this, I think in this session, I would like to continue to use AMC because altogether, both AMC and AMU are now known as AMU.
Okay, thank you, Susan. So ចឹងគាត់ចង់បញ្ជាក់ថាអ្វី method ដែលយើងធ្វើ monitoring ហ្នឹងដែលយើងប្រើប្រាស់កន្លងមកហ្នឹងគឺមានពាក្យថា antimicrobial consumption ហៅថា AMC ហើយនឹង antimicrobial use គឺ AMU ហើយភាពខុសគ្នារវាង AMC និង AMU ហ្នឹងគឺ AMC គឺគេ estimate ទៅលើការទាញយកទិន្នន័យហើយជាប្រភេទជា quantitative nature and គឺការ estimate ទៅលើការប្រើប្រាស់នៅឱសថប្រឆាំងមេរោគហើយមួយវិញទៀតសម្រាប់ AMU គឺជាការ estimate ទៅលើ patient level data ហើយវាជារបៀបថាហៅថា qualitative in nature ហើយគេប្រើប្រាស់វាដើម្បីវាយតម្លៃអំពីគុណភាពของការ prescribe ដូចជាការចេញវិជ្ជាបញ្ជាឬក៏ clinical practice អីអញ្ចឹងទៅលើ protocol ឬក៏ treatment guideline អីអញ្ចឹងទៅហើយជាទូទៅឥឡូវនេះគាត់ចង់ update ថាគេជាទូទៅគឺគេប្រើប្រាស់ពាក្យថា AMU ប៉ុន្តែដោយសារនៅក្នុងសភៅ guideline ហើយឬក៏ policy របស់យើងមានតាំងពី AMC និង AMU អញ្ចឹងគាត់ជាយាមឲ្យប្រើប្រាស់ពាក្យ AMC នៅក្នុងបរិបទរបស់យើងអីអញ្ចឹងណាបាទ
Okay, so with AMC, there are different ways of doing it as well. So there are 3 main approaches, and it sort of depends on what data is available to you. So the first is the DDD, or the defined daily dose, which is the most widely used international metric. And I think most of you have heard about DDDs because it's easy to calculate from dispensing, purchasing, or sales data. And, you could use it for benchmarking. So not just at the local level, but across, countries as well. Days of therapy is preferred for pediatric or neonatal populations because it measures the actual patient exposure, regardless of dose. And then you've probably also heard of PDD, which is the prescribed daily dose, which reflects the real local prescribing practice. So it makes it useful when you're sort of comparing prescribing behaviour. But you also notice that with DOT and PDD, that it requires prescription level detail. So often you would need to extract this kind of data from an electronic, computerized medication management system.
អូខេអញ្ចឹងសម្រាប់ AMC monitoring option របស់យើងហ្នឹងយើងមាន3វាយោងទៅតាមទិន្នន័យដែលលោកគ្រូអ្នកគ្រូឬក៏ option ដែលលោកគ្រូអ្នកគ្រូជ្រើសរើសក្នុងការតាមដានវាដែលក្នុងហ្នឹងវាមាន define daily dose មាន day of therapy ហើយនិង prescribe daily dose ហើយ define of daily dose ហ្នឹងគឺយើងការ collect ទៅលើការចែកចាយការទិញឬក៏ការលក់ទិន្នន័យនៅតកតងជាមួយនឹង antimicrobial ហ្នឹងអញ្ចឹងទៅហើយជាទូទៅគេប្រើ option នេះនៅក្នុង low resource setting ហើយប្រើប្រាស់ជាទូទៅនៅក្នុងថ្នាក់អន្តរជាតិផងដែរហើយសម្រាប់ day of therapy ហ្នឹងគឺគេ recommend សម្រាប់ matrix ទៅលើពពោះ pediatry ឬក៏ neonatal AMC អីចឹងទៅហើយគេ define measure ហ្នឹងគឺទៅលើជាទូទៅគឺ require computerized medication management system ហើយសម្រាប់ prescribe daily dose ហ្នឹងគឺវា reflect ទៅលើការអនុវត្តផ្ទាល់ទៅលើការចេញចាក់បញ្ជាហើយវាត្រូវបានទាមទារមើលទៅលើការ prescription level ហ្នឹងតកតងជាមួយនឹងការប្រើប្រាស់ប្រព័ន្ធគ្រប់គ្រងតាមរយៈ computer ឬ electronic អីចឹងទៅបាទ
So in this session, we will focus on the WHO ATC DDD system because it's a global standard for measuring medicine use and it provides a consistent way to monitor AMC across different settings. The major advantage with this is that the defined daily dose or DDD is actually a fixed unit of measurement. So you don't have to worry about medicine price, currency, pack size, or product strength. And this kind of standardized allows meaningful comparisons over time. So between hospitals, regions, and countries, and is valuable for identifying trends in antimicrobial use, and is usually the surrogate marker for evaluating the impact of AMS interventions and benchmarking performance as well, which MOH might be interested in implementing in the future. So the WHO ATC DDD methodology is now the most widely used metric in international and national AMC surveillance systems.
អូខេអញ្ចឹងសម្រាប់ថ្ងៃនេះយើងនឹង focus ទៅលើ DDD អញ្ចឹងដោយសារ DDD ហ្នឹងគឺជា method មួយដែលគេប្រើលក្ខណៈអន្តរជាតិជា international standard ហើយវាគឺងាយស្រួលក្នុងការប្រើប្រាស់method មួយហ្នឹងវិធីសាស្ត្រមួយហ្នឹងដោយយើងមិនចាំបាច់ខ្វល់ទៅលើប្រាយឬក៏ package size ឬក៏ភាពខ្លាំងឬក៏អីរបស់វាទេហើយវាត្រូវបានយកទាំងអស់ហ្នឹងយកមកប្រើឲ្យធ្វើការប្រៀបធៀបរវាង population group ឬក៏អីចឹងទៅហើយវាក៏ផ្ដល់ impact ច្រើនដែរហើយអ្វីដែលយើងអាចធ្វើបានហ្នឹងគឺDDD ហ្នឹងគេប្រើប្រាស់ជាលក្ខណៈ standardized program matrix ហ្នឹងមុននឹងពេលដែលយើងធ្វើ AMS intervention អីផ្សេងៗនៅក្នុងទីពេទ្យអញ្ចឹងយើងអាចប្រើ method បានហើយសម្រាប់មួយទៀតគឺអាហ្នឹងគេក៏ហៅពាក្យថា WHO ATC DDD methodology អញ្ចឹងគាត់ចង់ interview អាហ្នឹងឲ្យអ្នកទាំងអស់គ្នាបានស្គាល់អំពីអាហ្នឹងឲ្យកាន់តែច្បាស់អញ្ចឹងបាទ
Okay, so what is the actual methodology from the WHO? So it is based on the, you've probably heard of GLASS, which is the Global Antimicrobial Surveillance System. I'll show you some of that a bit later. And so WHO has actually published these guidelines for how to do it. So for a national program, for example, at MOH, there is a methodology for that. And then for hospitals, there are also guidelines for the different sort of what kind of data could be used and denominators and so forth. But overall, this list here, you can download from the WHO website, and they have actually prescribed as part of GLASS what they want to be measured. So they want the J01, which is all antibacterials. They want the elementary tract. This is if you participate in GLASS, for example, if MOH participates in GLASS, this is what they need to submit to WHO. So, and the P01 is usually about metronidazole used for protozoal diseases. And these ones here are optional. So just wanted to sort of show you that we can go into a lot more depth if we do it as a workshop. In this session, I cannot explain these in depth to you, but just to say that there are guidelines that needs to be followed when you're using the WHO methodology.
អញ្ចឹងនៅក្នុង slide មួយនេះគឺគាត់ចង់បង្ហាញតាក់ទងជាមួយនឹង WHO class AMC ហើយលោកគ្រូបានឃើញរូបរាងនៅពេលដែលយើងធ្វើការប្រម៉ូទទិន្នន័យឬក៏យើងទទួលបានជាទិន្នន័យនៅក្នុង system របស់យើងហើយ WHO ក៏បាន publish តាក់ទងជាមួយនឹង class ដែរសម្រាប់ National Surveillance System សម្រាប់ monitoring ទៅលើ AMC នៅក្នុងទីពេទ្យផងដែរហើយមួយវិញទៀតគេក៏បាន publish ទៅលើ class methodology សម្រាប់ surveillance national AMC ដូចគ្នាហើយលោកគ្រូអាច access នៅក្នុងតាមរយៈ online ហើយនៅក្នុងព័ត៌មានទាំងអស់ហ្នឹងអ្វីបើសិនជា MOH របស់យើងរួមតាក់មួយនឹង WHO កន្លះលោកគ្រូនឹងបានឃើញគឺក៏ព័ត៌មានមួយចំនួនដែលយើងត្រូវបំពេញនៅក្នុង program surveillance program ហ្នឹងដែលក្នុងហ្នឹងលោកគ្រូមានឃើញលេខកូដ J01 តាក់ទងជាមួយនឹង antibacterial អីដែលបង្ហាញនៅលើរូបភាពហ្នឹងអញ្ចឹងដែលជា core set សម្រាប់ define ទៅលើ antimicrobial នៅក្នុងប្រទេសរបស់យើងហើយអានេះគឺជា optional list មួយទៀតសម្រាប់ antimicrobial ហ្នឹងដូចជា antifungi antimycotic antiviral អីផ្សេងទៀតអញ្ចឹងអានេះគឺជា code សម្រាប់ការដែលយើងបញ្ចូលនៅក្នុងការតាមដានទៅលើ AMC របស់យើងហ្នឹងបាទហើយគាត់ថាកិច្ចការងារនេះគឺវារៀងស្មុគស្មាញហើយនឹងត្រូវការសិក្សាឲ្យស៊ីជម្រៅអញ្ចឹងនៅក្នុង presentation រយៈពេល1ម៉ោងនេះគឺយើងអាចធ្វើទៅបានទេអញ្ចឹងយើងនឹង invite ក្នុងករណីយើងមាន workshop ឬក៏យើងមាន training អីផ្ទាល់ in person អីនៅក្នុងប្រទេសយើងគឺយើងនឹងបរៀនលោកគ្រូឲ្យបានកាន់តែល្អទៀតទៅលើព័ត៌មានទាំងអស់ហ្នឹងបាទ
Okay, so the WHO methodology is based on the ATC DDD index. So while they produce those guidelines, you've got to be able to identify which of your antibiotics have got what. You've got to be able to assign the ATC codes with and then calculate the defined daily dose. So if I do this, okay. Did it come across, Vanderith? Can you actually see the live site?
No, we just see your presentation. Maybe you have to share another screen. Maybe another tab.
Another
I
time.
see
Okay.
an IPX something.
Yeah, okay. I will do that another time then. I was going to show you the live site, but yeah, that's okay. So the ATC DDD index is published yearly by a WHO collaborating center for.
Sorry, Susan. You show like the global AMU data, right?
So can you see my presentation or not?
I see the web that who.org something.
Oh, okay. So you can actually see. So you can actually see. You can actually see the live website. Is that correct?
Yeah,
okay.
Yeah.
Because I used the link from my presentation, and so I'm really glad you can see that. So the Norwegian Institute of Public Health, they publish yearly an index, an ATC DDD index, which is the authoritative source for this system, and is used as the primary reference for AMC monitoring. So you can see here that we do a quick search, that you can search by ATC code or medicine, and then it will spit out the defined daily dose for you. And there's also an index as well, or a few hundred pages, I think a couple of hundred pages, that you can also get access to, as well as an Excel spreadsheet, which needs to be paid for. But the website provides a lot of guidance in terms of the methodology, as well as all the updates. So it's very important that when you do AMC calculations, or I should say DDD calculations, that it's based on the correct version of the index.
អញ្ចឹងលោកគ្រូអ្នកគ្រូបានឃើញហើយថាគេមាន website ដើម្បីឲ្យលោកគ្រូអ្នកគ្រូអាច access បានដើម្បីគណនាទៅលើ daily dose define ហ្នឹងអញ្ចឹងគេព័ត៌មានទាំងអស់ហ្នឹងគឺគេ publish ជារៀងរាល់ឆ្នាំតែឆ្នាំម្ដងអីចឹងណាហើយយើងយោងទៅតាមព័ត៌មានដែលប្រមូលទិន្នន័យហ្នឹងហើយលោកគ្រូអ្នកគ្រូអាចទៅតាម website ATC ហើយយើងអាចវាយកូដ ATC ហ្នឹងដើម្បីគណនា DDD ហ្នឹងទៅតាមអ្វីដែលយើងចង់បានលេខកូដមួយហ្នឹងគឺដូចលោកគ្រូអ្នកគ្រូឃើញហើយយើងធ្វើអាហ្នឹងដោយសារតែយើងពឹងផ្អែកទៅលើព័ត៌មានដែលគេអាប់ដេតចុងក្រោយបំផុតដែលយើងអាចយកមកប្រើប្រាស់បានអញ្ចឹងដូចគាត់បានបង្ហាញនៅក្នុងវិធានហ្នឹងអញ្ចឹង
Okay, so let's just focus on the ATC component first. I think pharmacists know this quite well, and you'll find that most hospitals, it's actually the pharmacists who do the AMC monitoring. And that's because out of the pharmacy system, if it's already coded for ATC, then the ATC is based on 5 levels. So you can see that the first level is actually based on the body system. So it's anatomical. That's what A stands for, anatomical. And then after that, it's the therapeutic subgroup, followed by the pharmacological subgroup, chemical group, and then you end up with the name of the medicine. So if I went back and type in Triaxone, you can see that ceftriaxone is the J01DD04, and that's because it's classified as an antibacterial J01. It's a other beta-lactam antibacterial. It's a 3rd generation cephalosporin, and then it ends up with a 4 at the end for ceftriaxone.
អូខេអញ្ចឹងដោយលោកគ្រូអ្នកគ្រូបានឃើញអញ្ចឹងគាត់គិតថាខាង pharmacist ខាង pharmacist គឺគាត់នឹងយល់ច្បាស់តាក់ទងជាមួយនឹង ATC នឹងហើយគេមានជាលេខកូដរបស់គេហើយគេចែកចេញជា5 level ដោយលោកគ្រូអ្នកគ្រូបានឃើញក្នុង screen អញ្ចឹងខ្ញុំអត់ចាំទេតាមវិធាននីមួយៗហើយពេលលោកគ្រូចង់ដឹងអំពី ATC កូដហ្នឹងលោកគ្រូវាយឈ្មោះឆ្នាំទៅហើយលោកគ្រូអ្នកគ្រូចូលទៅកាន់លេខកូដរបស់គេហ្នឹងដូចឃើញនៅក្នុងរូបអញ្ចឹងគឺគេបង្ហាញព័ត៌មានថាតើពពួក ceftriaxone ហ្នឹងគឺគេប្រើប្រាស់របៀបម៉េចហើយបង្ហាញពី DDD នៅក្នុងហ្នឹងតែម្ដងអញ្ចឹងជាការងាយស្រួលដែលយើងទទួលបានព័ត៌មានអាប់ដេតចុងក្រោយបំផុតដែលគេប្រើប្រាស់នៅក្នុងពិភពលោកអញ្ចឹងណាបាទ
Okay, so that's what ATC stands for. So you start off with the body system and then the therapeutic group, and it ends up with the name of the substance at level 5. So we went through those 5 levels before. So level 1 is the system, level 2 is the therapeutic group, and then level 5 is the chemical. So there are 5 levels. You saw that in the ceftriaxone before. Maybe I will progress this if it's okay, Bandarith. And here is the summary again. Okay, so we looked at that summary live before on the website, on the NIPH website. Okay, so that's how ceftriaxone got its ATC code. So you can see there, J is for the body system or anti-infectives, right? And then bacterial, and beta-lactam, cephalosporin, and then ceftriaxone. I might just move along because I know we're I've still got many slides. All right, just this slide here is just to tell you that there are drugs that have got more than one ATC code. All right, so if you look at metronidazole, it's a J01 here because it's used to treat anaerobic infections. But here you can see that it's used to treat antiparasitic infections like Giardia. You might have metronidazole vaginal cream and even, metronidazole gel for acne, for example. So one drug can have multiple ATC codes based on the system that's been used to classify it.
I think Susan, you can move forward because
it's
it is
quite
very
technical.
technical.
Yeah, it is very technical. So I think the pharmacists and doctors will understand this. So I just want to say that, okay, so certain medicines have more than one code. And then the defined daily dose is the average maintenance dose for a drug. Okay, so and used for its main indication in an adult. So we're assuming a male of weighing 70 kilos. And DDDs for anti-infectives are based on infections of moderate severity and should not be considered as a correct dose. So I think pharmacists will understand this quite well. The DDD itself is not an individual dose for the patient. It's not a prescribed dose. So the WHO Collaborating Centre in Norway will meet every year and they will go over the whole list of medicines which are in their database, and they will assess the DDD. So a group of global experts will assess the dose of they will come up with the DDD. Okay, so it's not based on whether the patient's got a renal impairment, and we spoke about DOT before. So for children, the DDD is not really that applicable because it's based on an adult male weighing 70 kilos. And it doesn't actually correspond to, even body weight or anything like that. It is a compromise that global experts have agreed on, that this is the average maintenance dose. Vanderes, do you need to explain this or? No? Okay. All right, so it is based on the main indication, maintenance dose, as well as the administration form. So I don't really want to go too much into this, because if you use the DDD, you have to accept the actual DDD itself. We cannot change it. So worldwide, only the WHO Collaborating Centre will have the ability to change the DDD. But like I said before, for antibiotics or antimicrobials, it is based on the maintenance dose instead of like loading dose and things like this. It is at compromise in terms of the dose. Okay, so moving on, just to say that we spoke about the maintenance dose, but the DDD will be different based on the route of administration as well. Because pharmacists, you know quite well, and doctors as well, that, for example, here, ciprofloxacin, the oral dose and the parenteral dose are different, even though it's got very good bioavailability, almost 90%, but they are different. So the DDD for the dosage form will be different. And you can see here as well, the oral metronidazole dose compared to the parenteral. I know we sort of use BD, but 500 TDS is still the sort of DDD. And just to also mention that there is only one DDD for each ATC level 5 code. Okay. So in terms of the alterations, I don't think there are very many. Up to 2019, they did a massive sort of altering the doses of antibiotics. But I couldn't, going through the list, couldn't really pick. I don't think they've made very many adjustments in terms of antimicrobials in the past 5 years or so. But they've had to increase. You can see that they've increased the DDD of meropenem, for example, and ampicillin was only 2 grams per enteral. That was very low. Now it's gone up to 6. Okay, so we can look up the list here, or maybe I'll keep going, Vanderith. Yeah, in the interest of time.
Yeah, please.
Yeah. And people can play, like I will share my presentation at the end of this, and people can use the links to have a look at the resources.
ពេលចឹងលោកគ្រូគាត់នឹង share slide ហើយលោកគ្រូបើចង់សាកល្បងក្នុងការប្រើប្រាស់អីអាចប្រើ link នៅគាត់នៅក្នុង presentation ហ្នឹងអាច click ដើម្បីចូលមើលបន្ថែមទៀតអីអញ្ចឹងណា
Okay. So if there are other philosophies for assigning the ATC code. For example, if you're looking at say, Augmentin or something like that, so amoxicillin with a beta-lactamase inhibitor, it will have a DDD, but it's based on the main active ingredient. So it's based on amoxicillin. You won't be using, for example, clavulanic acid. And for combination products, this is really, really confusing. So like something like cotrimoxazole here, you can see that the unit of the DDD is actually not in grams. So it's in a unit dose. And that's because you've got 2 active ingredients. Oh, oops, sorry. So you've actually got 2 active antibiotics. So we cannot say that the DDD should be based on trimethoprim or sulfamethoxazole. So calculating cotrimoxazole is one of the most confusing DDD to work out. Okay. I know this is all very new to you, and that's why I said at the beginning of my talk that this is something that should be in a workshop. So when we've had to teach our fellows on how to assign ATC codes, how to calculate the DDD, that it will take months to be able to download the data and go through, clean it up, and then to even analyze it. So it's not something that I can teach in just a half an hour. It's something that if you're interested in, we can look at further down the track.
ចឹងគាត់បានលើកឡើងថាកិច្ចការងារនេះគឺវាត្រូវការពេលវេលាដើម្បីឲ្យយើងជួបគ្នាដើម្បី training ឬក៏អីចឹងដូចជាធ្វើ workshop ឬក៏អីចឹងណាហើយការគណនាអ្វីដែលគាត់បានបង្ហាញនេះគឺជាអ្វីដែលថ្មីដែរហើយយើងត្រូវការធ្វើការងារហ្នឹងដើម្បីទាញទិន្នន័យការ clean ទិន្នន័យហើយមើលជាមួយគ្នា assign code អីចឹងទៅដើម្បីធ្វើការគណនាទៅលើអ្វីដែលគាត់បានបង្ហាញហ្នឹងអីចឹងណាបាទតែឥឡូវនេះយើងគ្រាន់តែ introduce ដើម្បីឲ្យលោកគ្រូអ្នកគ្រូបានស្គាល់សិនបាទ
So I've just covered the ATC code. how to actually get that from the index, and you know, how the DDD, how a DDD is assigned to that ATC code based on the route of administration as well as the active ingredient. And there are lots of other things that needs to be considered for combination products. And here I've given you an example for just to see, so that you know, to calculate the DDD. So for example, if you used 30,000 grams of ceftriaxone, which is hopefully too much, you know, the DDD set by the WHO Collaborating Center in Norway assigns a DDD of 2 grams for ceftriaxone, and that you have had 6,000 bed days for that month. So for example, this is for hospital. So you can see that 30,000 grams divided by 2 grams will give you 15,000 DDDs for that month. And the reason why we want to convert it to 100 bed days is so that we can compare it to other hospitals, and we can compare it across the world. Because without a rate, we can say, well, then China's got 1.4 billion people, their DDDs would be off the charts compared to yours. So that's why if it was a national program, it would be compared across the size of the population, which then becomes a 1,000 inhabitants per day, or what we call a DID. But when it's a hospital, we would compare using 100 or 1,000 bed days for the activity of that hospital.
អូខេអញ្ចឹងកន្លែងនេះគាត់ provide ជា example ក្នុងការគណនាទៅលើ ceftriaxone ហើយលោកគ្រូលើកឃើញអញ្ចឹងគឺអ្វីដែលយើងបានប្រមូលទិន្នន័យមកដូចយើងថា30គីឡូក្រាមស្មើនឹង300,000 ក្រាមអញ្ចឹងហើយ WHO DDD for ceftriaxone ហ្នឹងគឺគេ recommend សម្រាប់2ក្រាមហើយ bed day demand ហ្នឹងគឺ 6,000 អញ្ចឹងរបៀបក្នុងការគណនាគឺគេយក 3,000 ចែកនឹង2ហើយយើងនឹងឃើញ 15,000 DDD ហើយគេយក 15,000 ហ្នឹងទៅចែកជាមួយនឹង6,000 ចែកនឹង100ទៀតហើយវានឹងធ្វើ250 DDD ក្នុង100 bed per day អញ្ចឹងការគណនានេះគេធ្វើដើម្បីធ្វើការប្រៀបធៀបរវាងពីមន្ទីរពេទ្យមួយទៅមន្ទីរពេទ្យមួយបើសិនក្នុងករណីវាជា National Program យើងអាចប្រៀបធៀបជាមួយនឹង Global ដែល WHO គេបានសិក្សាអីចឹងទៅថាតើ DDD នៅក្នុងស្រុកយើងប្រទេសយើងគឺមិនដែរសម្រាប់ការប្រើប្រាស់ហ្នឹងដែរ
Okay, so these are some of the advantages and disadvantages. Just to say that DDDs were not really specifically developed for AMS. DDDs have been around since in the early or late 1970s, actually. So, you know, they were developed for drug utilization studies, not necessarily for AMS. So it's not a perfect measure. And the advantages, I think we spoke about before, but there are some disadvantages which I also mentioned about, you know, using it, you know, to measure AMS programs in pediatrics. DOT is the way to go because it's not dependent on dose. And then I think, you know, there's that compromise. So it's not a prescribed dose. So it might underestimate use because, you know, it doesn't account for obesity or, you know, any of the renal or liver dysfunction. And there is a bias as well against combination therapy. For example, we could be using triple therapy, you know, amoxicillin, metronidazole, and gentamicin. That's 3 antibiotics generating 3 DDDs instead of using, you know, the one ceftriaxone or another 3rd generation cephalosporin. So, you know, if you use more narrow, sometimes there could be a bias against using more narrow spectrum combinations. And that it's not really a dose for any particular infection.
គេអញ្ចឹងសម្រាប់DDT ហ្នឹងគឺវាមានអត្ថប្រយោជន៍ហើយនឹងគុណវិបត្តិនិងគុណសម្បត្តិរបស់វាដែរអញ្ចឹងណាលោកគ្រូអាចមើលទៅតាមអ្វីដែលគាត់បាន explain ទៅលើគុណវិបត្តិហើយនឹងគុណសម្បត្តិរបស់វាហើយ DDT ហ្នឹងគឺគេបង្កើតវាមកគឺមិន specific ទៅលើការ monitor ទៅលើ impact សម្រាប់ការធ្វើ intervention ទៅលើ AMS ទេហើយវាក៏មិនជា method មួយក្នុង perfect ក្នុងការវាស់វែងដែរប៉ុន្តែលោកគ្រូអាចមើលបន្ថែមទៀតបានឲ្យបាន detail ទៅលើ advantage និង disadvantage ហ្នឹងអញ្ចឹងបាទ
Okay, so where would you get your data from? And you can see this is the pharmaceutical value chain, so from R&D right through to use by the patient. And for AM, usually we'll look at, at a national program, it's usually sales data, manufacturing, import, procurement and supply, or even, in Australia, we do use our insurance data. You can look at prescribing and dispensing data, usually dispensing data in a hospital. And then we don't really look at DDDs, at the patient level. So the point to make here is that the higher the point for the data extraction, so moving this way to dispensing, then you have better validity of your data. But I think you can actually do that in Cambodia because you've got electronic dispensing systems.
អញ្ចឹងដោយលោកគ្រូអ្នកគ្រូបានឃើញនៅក្នុងរូបហ្នឹងអញ្ចឹងនៅក្នុងនេះគឺក៏មានបង្ហាញនៅក្នុង National AMC Guideline របស់យើងនៅស្រុកខ្មែរដែរអានោះតាមខ្ញុំចាំណាហើយតើយើងបានទិន្នន័យ AMC ហ្នឹងមកពីណាដោយលោកគ្រូអ្នកគ្រូឃើញនៅក្នុងរង្វង់ antibiotic consumption ហ្នឹងអញ្ចឹងគឺវាមាន selection pricing reimbursement ឬក៏អីចឹងយើងគិតអំពី procurement and supply prescribing and dispensing ហើយនៅក្នុងហ្នឹងដូចយើងឃើញថានៅស្រុកខ្មែរយើងគឺអាចធ្វើបានដោយសារការធ្វើ dispensation របស់យើងហ្នឹងគឺប្រើជាលក្ខណៈ electronic អីចឹងណាអញ្ចឹងយើងអាចធ្វើកិច្ចការនេះបាន
So I just to say that, in terms of the data, I will show you the WHO AMC website shortly. I think as you are starting to think about AMC, depending on it needs to be stakeholder specific. So I suppose for a policymaker, it would be some countries find it easier to use sales data and import data because they have that. And then hospital, if it's dispensing data, the data source, I think, needs to be a realistic source. And you've got to be able to think about how it might even evolve over time. And, the resources required to actually extract that. So, for example, in hospitals moving into the community. So I think the actual data source will depend very much on the stakeholder and what they actually need in terms of the AMC data. What is it? What question do they actually want answered will determine where to get the data from.
អញ្ចឹងសម្រាប់data source ដែលយើងត្រូវប្រើប្រាស់ហ្នឹងវាមានលក្ខខណ្ឌជាច្រើនដែលយើងត្រូវ consider ពិចារណាក្នុងការប្រើប្រាស់វា depend ទៅលើdesirable របស់យើងហើយនឹង realistic ក្នុងការអនុវត្តអញ្ចឹងថា stakeholder របស់យើងទាំងអស់ហ្នឹងដែលមានហ្នឹងគឺគាត់មានអីគេខ្លះដើម្បីអាច promote ទិន្នន័យទាំងអស់ហ្នឹងបានតែ quality ហ្នឹងមិនដែរហើយវាអាចធ្វើការផ្លាស់ប្ដូរ over time ទៅតាមអ្វីដែលយើងចង់បានអីចឹងអាហ្នឹង based on ការ consideration ជាមួយនឹងគ្រប់ដែលយើងធ្វើការពិភាក្សាបាទ
Yeah, so I think at a hospital level there is probably less variation, but at a national level, certainly when we're starting to establish an AMC monitoring system, there's different levels of data. There's the national sales and marketing data, which is more representative of the country's data overall. And then the next level down will be provincial data, whether that's important at all for decision making by provinces. In Australia, we have that, stratified against the states, and then, hospital and community. And so the other, what I've actually seen too, working with Pakistan, Timor-Leste, Nepal, Bhutan, and even in Vietnam, is that the informal market can also be quite a significant, if you, for example, one country that I worked with to develop the national AMC system, it's not really representative of the country, because 70% of the supply is from the informal sector. So the WHO GLASS could not accept that data because it's not representative enough. I might move on. Then I just want to talk about, now you've got your ATC codes assigned, you've got your DDDs calculated. So for comparison, you can just report your DDDs, that's fine for your hospital. But if you want to compare, then at a national level, you've got to have, like we said before, the population size. Then you'd be able to benchmark yourself against similar countries. And at the facility level, we need to know what the activity of the hospital is. So occupied bed days, for example, is say at 8 a.m. in the morning, and you have 10 beds at that hospital, all 10 beds were occupied. So that day, the occupied bed day is 10. And then over a week of 7 days, if they were all occupied, then that's 70 occupied bed days. So you can't really use population data at a hospital because it's not, it doesn't reflect who is exposed to care. And so we do need to have, if you're able to calculate occupied bed days, the real patient exposure within the hospital ward. And it's usually expressed, the rate, as a DDD per 100 occupied bed days, or you will also see 1,000 occupied bed days. So be very careful when you're reading the literature. WHO is based on 100 occupied bed days.
អូខេអញ្ចឹងខ្ញុំសូម summary តិចទេហើយអញ្ចឹងលោកគ្រូអ្នកគ្រូឃើញថាទិន្នន័យរបស់យើងត្រូវការធ្វើការប្រៀបធៀបអំពី population size ឬក៏គេហៅថា denominator អញ្ចឹងទៅហើយនៅក្នុងនោះគេបែងចែកចេញជាពីរគឺ national level data ហើយនិង facility level data អញ្ចឹងសម្រាប់ national level data គឺយើងប្រើ denominator ជា population size ហើយសម្រាប់ facility level data គឺយើងប្រើ occupied bed day ហើយលោកគ្រូអាចមើលហើយនឹងគាត់បាន explain ខាងដើមទាក់ទងជាមួយនឹងការប្រៀបធៀបហ្នឹងគឺដែលយើងជ្រើសរើស denominator ហ្នឹងហើយគាត់បានបញ្ជាក់ថានៅក្នុង facility level យើងអាចប្រើ denominator ជា population size បានទេអញ្ចឹងយើងប្រើជា occupied bed day ទៅតាមអ្វីដែល WHO បាន recommend ហើយគេក៏បង្ហាញអំពី DDD over 100 occupied bed day ដែរនេះគឺជាអ្វីដែល WHO គាត់ recommend អញ្ចឹងបាទអរគុណ
So here, all I wanted to mention is that AMC is usually used as an outcome indicator for measuring AMS interventions. That's what it's mainly used for. So there are other monitoring indicators for your stewardship program, which we're not covering here today. But AMC is normally one of those as an outcome alongside AMR rates.
អូខេអញ្ចឹងយើងក៏មានជា monitoring indicator ដែរដែលនៅក្នុងនឹងគេមានជា structure indicator process indicator ហើយនិង outcome indicator សម្រាប់ការ monitoring ទៅលើ stewardship intervention អីផ្សេងៗ
Okay, so I think we've covered that. For hospital consumption, it's a DDD per 100 or 1,000 occupied bed days. For a national system, usually, or in the community, it's usually per 1,000 inhabitants per day. And these are the recommended indicators by WHO. So to dissect or stratify the data by the pharmacological subgroup and route of administration, now more by aware categories, and the DU75 or the DU90, which is the list of most frequently used antibiotics.
អញ្ចឹងសម្រាប់ indicator នេះគឺជា recommend របស់ WHO ទេយើងអាចប្រើប្រាស់ជា 1000 occupied bed day សម្រាប់hospital level ហើយបើសិនជាយើងធ្វើនៅក្នុង community ឬក៏ population គឺយើងប្រើ DEE 1000 inhabitant per day បាទហើយយើងមានជា indicator ផ្សេងៗទៀតដូចជា pharmacological subgroup ហើយនិង road of administration aware category ឬក៏ frequent of substance use អីចឹងទៅដែលកំប្រែ 75% នៃ total consumption បាទ
I just want to explain something like the DID, which you'll hear a lot of, is if you say, for example, you have 10 DID, which means that you have 10 DDDs per 1,000 inhabitants per day, then basically what that means is that in a group of 1,000 inhabitants, a representative group of 1,000 inhabitants, 10 DDDs on average is given in that year. So you can sort of view it as 1%. So 10 over 1,000 is 1% of the population is receiving that antibiotic each day in that year. Okay. All right, so now just wanted to look at how the data is used for stewardship. And WHO uses this information for a lot of the political advocacy. So at an international level, that's why they collect AMC through GLASS, and you can see here, the GLASS AMC is one of their flagship, I suppose, surveillance system. So GLASS is composed of, many of these different programs, and AMC is one of them, and you've been doing the PPS AMU as well in your hospitals, and they report that. The last report was in 2022.
អញ្ចឹងសម្រាប់ទិន្នន័យ AMC ហ្នឹងគឺយើងអាចប្រើប្រាស់បានជាខ្លះដោយលោកគ្រូបានធ្វើភាពទាក់ទងជាការបង្ហាញទាក់ទងមក global anti AMR and use surveillance system ហ្នឹងគឺយើងអាចប្រើប្រាស់ទិន្នន័យ AMC AMU ហ្នឹងសម្រាប់ការធ្វើជា surveillance of AMC ឬក៏ point prevalence survey អីផ្សេងៗបាទ
Okay, I think this might work. And if you're interested, you can have a look here, but Cambodia is not, you're not contributing to the AMC data at the moment. But if you are, you can actually check here. Say, for example, where we choose the Western Pacific region, which you're part of. The data there is 2023. And then you can see which country has submitted the data, how the aware categories are looking. They have, are they here? That's for all countries that have participated in AMC. So you can have a look later. In Australia, we have what we call the national the national system for AMC, which is voluntary, and I think there are about 300 hospitals now that participate in this. So this is for our national surveillance system. So again, this is for policymakers. So we've gone from international use, so by WHO now down to a national program or a national surveillance program. So here I'm just giving you an example of what we do in Australia, but I'm sure, Professor Kim in the future will be looking at how the AMC system will look like for Cambodia. So you can see here, we can compare our states or your provinces. We can do it by usage rates as well, like based on the subgroup of antibiotics, and then by aware categories like access, watch, and reserve, and compared against the states. So this is benchmarking, which policymakers usually would like to have for their surveillance program. Okay, then moving along for hospitals, I know we have a lot of clinicians here as well. So at the Royal Melbourne, the hospital that we're affiliated with, this is how they've been using the data, but the stewardship program at the Royal Melbourne is like almost 20 years old. So, and they've been submitting Norse data probably for 20 years as well. So using it, for example, if you've introduced a new change in your guidelines, such as switching people from Gent over to amikacin in ICU, you can actually have a look at the trends over time as to whether it's gone up, whether gentamicin has gone down. And for example, if you know, just introducing new guidelines, PIP-TAS versus amoxiclav, so you can actually see what's been happening as well over the period that you're doing your new guidelines implementation. And then I think initially for your hospitals, and I could actually see that when I was in Calmet and Consumac, I think it's really about identifying the areas for further investigation. I know there's quite a lot of meropenem use, for example, at Calmet, so you could actually see which ward, you know, the consumption over the past 3 years. You can look retrospectively at consumption over the past 3 years, to see where it's been distributed to in the hospital, which ward, and you know, and compare that. You won't be able to look at appropriateness. That's what you've been doing for the PPS. But in terms of AMC, you'll be able to see trends, whereas your PPS is mainly a snapshot. Oh, sorry, Vanderus, do you need to explain?
No.
Okay. And then moving along, these are examples that what we've been doing with our fellows. So you can look at, you know, the top 5, top 10, or the drug usage of the, you know, top 75% or top 90% of consumption of your antibiotics, and you can look at which ones. Yeah, so here in this hospital, this is a national hospital, ceftriaxone came out as the highest consumption. And then this here is quite interesting too. You can see the watch antibiotics have actually decreased as well. This is obviously had, you know, COVID's actually had an impact on the consumption there. What I wanted to say here is that at the Doherty, we actually have our own AMC tool that we teach hospitals on how to collect the data, and also how to assign the, you know, the ATC and DDDs. And it also comes with sort of preloaded graphs, like pivot tables, that will just spit out graphs like this for you. This here is based on the GLASS AMC tool. So this here is national data in one country, and MOH has used the WHO AMC tool to capture all the data. So here you can see it's, you know, DDD per 1,000 inhabitants per day, which is fairly high in this country. So what that's saying is that on any given day in the year, you actually have 80 patients in 1,000 on an antibiotic. And so this is an example that I recently found. It's still an article in press. So in Sri Lanka, they have done a 5-year trend analysis in one of their national hospitals. And if you're interested, you can also go and read that. It's still in press. But what I actually derived from this study is that this hospital uses more than 70% of their antibiotics in the access group, mainly oral antibiotics, and that's because they also did inpatients and outpatients. So you'll find that a lot of the AMC monitoring is done in inpatients and not in outpatients, but this hospital, it was possible to do both inpatients and outpatients. So outpatients, they did it as per 1,000 patients seen. It's because it's not in, they're not omitted, so it's not an OBD. And here they didn't have OBD data, but they were still able to do the analysis based on 100 admissions. So it's not like it's impossible to do. So what I actually want to say here is that if you've got pharmacy supply data and you can collect some of these denominators, you can still do AMC monitoring. Perhaps if it's not OBD, it's a bit harder to benchmark yourself to other hospitals around the world. But then if it's an improvement, you know, if you look at it from an AMS improvement perspective, you can also just look at the trends over time to see whether it's going up or coming down or what's actually happening. And they were able to demonstrate that, you know, it was trending down, but also maybe COVID had an impact. I think across the world, COVID did reduce the consumption because people weren't going to hospitals for treatment. And then they also had an economic crisis. So they were able to demonstrate that, you know, the DDDs had actually fallen between, you know, the 2021 to 2023 timeframe. Yeah, and then they were able to identify which antibiotic that they needed to look at in more detail, because amoxiclav was, yeah, the single most used. So you can actually hone in on, you know, dedicated PBSs or dedicated audits to look at what it's being used for, whether it's appropriate or follow guidelines. Yeah, and so I thought using this is, don't just collect data, but how are you going to use the data for your stewardship program? Yeah, and looking at inpatient versus outpatient, which is quite interesting. In Vietnam, we also had a hospital which in the south, which was 3,000 beds, and they actually did use AMC to you know, randomly audit their outpatients because they knew that that was going up, and just by random audits they were able to bring consumption down and change prescribing behavior because the clinics didn't know who was going to get audited. So yeah, because it was random and they know that Big Brother was watching, and they were able to bring down the consumption that way. So they knew also the DU, the drug utilization, 90% is just based on 11 to 12 drugs. So you can list out your top 10 drugs, or, you know, if you wanted just to do the 75% top used or consumed antibiotics. And this here, I just wanted to comment that we're seeing more and more people use the access to watch ratio. And here in this study, it was more than 2, which is sort of good. But, you know, there's you need to have caution using the ratio because certain hospitals, like national hospitals, have complex patients and very sick patients. And then if you're looking at, you know, between different wards, ICU is going to have higher consumption of watch antibiotics. So they will have a lower ratio compared to like a, you know, like a psychiatric ward or maybe maternity ward, or, you know, a hospital, which is more of a district hospital compared to a, you know, a quaternary or tertiary care hospital. So I think it's very doable because I've been to Calmet and Cosamac, and I think your electronic pharmacy systems can certainly do AMC monitoring, and yeah, and do all this analysis. So there are, you know, yes, if you want to report to GLASS, use the WHO tool, which we find very, can be a bit more cumbersome because you need to determine pack sizes, and they want to do market shaping as well. So which manufacturer and, you know, what kind of, which importer or manufacturer has more of the market, that kind of thing. our tool is a lot more simple. If you really want to head down that path, I can teach you how to use that. So just wanted to, this is almost my, this is my last slide actually. So again, just wanted to reiterate that, you know, it's not just about collecting the data, it really, you know, analyzing it, collecting it, analyzing it, discussing it, and then what? So for stewardship, you know, can you use the data to update your formulary control, which I think, you know, is quite important, because when I was there, the two hospitals had very different access to antibiotics. So one had free access and the other one didn't. So, you know, the tighter formulary control can certainly be introduced as well, so that meropenem isn't just prescribed, you know, without review. And then once you've introduced the intervention, using AMC to actually track how that intervention is going. And there's so many case studies of that, you know, national systems from Korea, Australia, right through to many other places. So yeah, just wanted to say, don't collect data for the sake of collecting data. We need to use it for something, for policy making, for implementing stewardship programs, or, you know, for tracking and monitoring how we're doing once we've implemented AMS. I think I will stop there. Hope you found it helpful. It's not an easy, yeah, not easy to teach online.
Okay, so thank you so much, Susan. And ចឹងឥឡូវនេះ Susan គាត់បានបញ្ចប់ presentation របស់គាត់ហើយចឹងលោកអ្នកគ្រូមានជាសំណួរអីអាច if you have any question please raise up and ask Susan because she is an expert in this area, so please. Ok, ចឹងលោកគ្រូអ្នកគ្រូមានសំណួរអីអាចសួរបានតាមឆាតក៏បានឬក៏លើកដៃទៅអាចបើកសំណួរដើម្បីសួរសំណួរគាត់អីចឹងណា
Wonderful. Thank you, Susan, for presentation about AMC. Currently, we also have the AMC guidelines. So until now, we cannot train our local AMS team how to implement this AMC guideline. So based on your presentation, that's very good, and how we can move to train on the implementation of the AMC guidelines and the full scope. Then we can have some data submit to the VPRAX. Yesterday, I met WO team and we also discussed with this, and Mr. Lacroix, the regional office now in WO in Manila, also insist to provide the AMC training. So, but as you know, currently WO has limited budget to support this activity. So maybe your organization could work with us how to move to train our team to implement the AMC guidelines. So this was my comment. So thank you very much. So back to Wonders and team how to respond.
Yes,
Thank you,
thank
Professor.
you. Yeah. Sorry, Vandus. Thank you, Professor Kim. Yeah, we would be, I think Rod would agree with this as well. We are visiting in November, the end of November, beginning of December. So maybe we could factor in, you know, a workshop or something, a 2-day workshop on AMC, or maybe a 1-day workshop, depending on how much training you need. We have been doing AMC training now for 5 years. So have gained a lot of experience, so not just in Australia, but across the Asia Pacific. So very, you know, happy to share our learnings with you. And I know, you know, different stakeholders will have, you have different requirements. So even if you're thinking of building a national AMC surveillance system, yeah, that is different to what clinicians want on the ground for their AMS programs. And so we have been through all the different levels of AMC, national AMC for, you know, and right down to provincial AMC and distribution and looking at what's happening at the province level right through to hospital AMC. So all three levels of AMC with practical experience.
Now, Susan, there is just one question in the chat. If you can answer that one quickly, otherwise maybe respond offline.
Oh, combination is quite complex pollen. So yeah, and some combinations don't have UD as well because the WHO Collaborating Centre won't publish them because they don't want to encourage the use of combination antibiotics. Yeah. So normally, so for cotrimoxazole, I can go through with you if you really like to work out the UD from mixtures to just the basic tablet to the double strength to the, you know, the ampule. It's quite mind-boggling to actually work out the DDD. So we can do that together if you like.
ចឹងលោកគ្រូចង់បន្តពីអ្វីដែល Susan គាត់បានឆ្លើយតបជូនលោកគ្រូជូន Professor ចឹងដោយសារតែយើងនឹងមាន trip មួយនៅខែ November ឆ្នាំ 2026 នេះអញ្ចឹងគាត់ថាយើងអាច support 2-day workshop ដើម្បី training ទៅកាន់បុគ្គលិករបស់យើងអញ្ចឹងណាហើយសង្ឃឹមថាយើងនឹងបញ្ចូល agenda ហ្នឹងនៅក្នុង trip របស់គាត់ហើយពួកយើងនឹងធ្វើការជាមួយលោកគ្រូដើម្បីធ្វើជា concept note ឬក៏ព័ត៌មានការជា agenda ដើម្បីរៀបចំបេសកកម្មអីផ្សេងៗដើម្បីកំណត់ថ្ងៃថាយើងយកថ្ងៃណាអីចឹងបាទលោកគ្រូ
Okay, good.
ក៏យើងអាច support បានបាទ
Yeah, good.
សម្រាប់បូកថាខ្ញុំសង្ឃឹមថាយើងនឹងមាន discussion បន្តទៀតពេលដែលគាត់ visit នៅស្រុកខ្មែរហើយនឹងអញ្ជើញបងឲ្យចូលរួមដើម្បីធ្វើការ training ហើយនឹងពិភាក្សាវាឲ្យកាន់តែ clear ជាងនឹងដោយសារតាម online វារៀងពិបាកអញ្ចឹងណាបងអញ្ចឹងយើងនឹងមានការ discussion ជាច្រើនទៀតនៅ November ហ្នឹងខ្ញុំសង្ឃឹមថាលោកគ្រូអនុញ្ញាតឲ្យពួកយើងបាន training ចាប់ផ្ដើមតាក់ទងនឹង AMC នឹងតិចម្ដងមុនពេលដែល plan របស់យើងទៅដល់អញ្ចឹងណាដែលថា plan យើងនៅចុងឆ្នាំ 2028 នោះតែយើងចាប់ផ្ដើមតិចពីពេលឥឡូវទៅដើម្បីឲ្យគ្នាយើងបានស្គាល់បានយល់អានឹងកាន់តែច្បាស់បន្ថែមចំណេះដឹងពីលើហ្នឹងបាទ
I might just answer Dr. Sokchan's question as well about whether we need to do all antibiotics or all antimicrobials. That's actually up to you, I think. But if you, as a national program though, if Professor Kim wants to submit to GLASS, then WHO will have the minimum set that they want. And it's all J01 or antibacterials. And like I said before, like some of the you know, for example, tinidazole or metronidazole used for giardia or antiparasitic. But for your hospital, if you don't have the resources, you could just do meropenem if you want. But we would recommend to do at least all the antibacterials if it's not too difficult. And I don't think pollen's online, whether it's that difficult really to extract the data from the pharmacy system. I didn't get the chance to do that at COSAMAC, or I didn't get to see the pharmacy dispensing system. But we could also, you know, work on a sample set of data when we do the training, and then you can decide for yourself how difficult. I think Dr. Sokchan, maybe you can ask your pharmacy department as well, how difficult it is for them to extract the data. because that will determine how many antibiotics you do. Because
Okay,
like in our
uh,
hospital, it's a bulk, like you can just run a report, bulk export into Excel. So it just depends on, check with your pharmacy department.
អូខេអញ្ចឹងបងចាន់អាចគាត់ឆ្លើយសំណួរបងណាបង ចឹងលោកគ្រូអ្នកគ្រូមានជាសំណួរអីទៀតទេ Okay, so I think that it is now that's all from them, and thank you so much everyone for joining. I would like to invite Rod for uh, a closing remark for this session, please. Rod, please.
Oh, sorry.
Okay.
Yeah, thank you everyone for joining today, and thank you, Susan, for, as we said, it's very difficult to do it in one session, but it really is just an introduction, and we do hope to do some more specific education and training on auditing, and in particular AMC and AMU audits later throughout the combat program. Next month's topic is going to be infection prevention and control, and mainly around outbreak investigations and how we might do some sampling and patient surveillance. So we welcome you to join us next month again. We'll send out some details of that soon. And thank you for everyone attending today, particularly to Susan on her presentation, and Professor Kim as well for our introduction. And thank you again, Vanderith, for your interpretation during the talk. Thank you so much.
ចឹងសូមអរគុណច្រើន Rod. Thank you so much, Rod, and thank you everyone for joining. Hi, next session យើងនឹងនិយាយតាក់ទងមួយ IPC ហើយនឹង outbreak investigation សង្ឃឹមថាលោកគ្រូអ្នកគ្រូនឹងអាចចូលរួមទៀតដើម្បីបានរៀនអំពីចំណេះដឹងថ្មីៗយ៉ាងហោចណាស់ព្រោះយើងបានទទួលអីដែលថ្មីអំពីការ update នៅក្នុងសកលលោកដែរដែលសារពួកគាត់ធ្វើកិច្ចការងារនេះរាល់ថ្ងៃអញ្ចឹងណាហើយជាចុងក្រោយលោកគ្រូមានអីពាក្យពេចន៍ផ្ដាំផ្ញើអីលោកគ្រូសូមអញ្ជើញ Professor Sapun a little bit.
Okay, so thank again for this session, especially Susan, the very comprehensive presentation, and Wander also try to translate. And our team here who spend more time to attend Zoom training session in this. So yeah, we hope we will continue working with you and for like coming session and other activity. So I would close this session. So thank you very much.
Thank you.
ចឹងអរគុណច្រើនលោកគ្រូហើយអរគុណអ្នកទាំងអស់គ្នាដែលបានចូលរួមនៅក្នុង training session នេះហើយសង្ឃឹមថាជួបគ្នានៅខែក្រោយទៀតបាទអញ្ចឹងសូមបញ្ចប់ Zoom ត្រឹមនេះចឹងសូមគោរពជម្រាបលាទាំងអស់គ្នាបាទអរគុណ
Thank you Susan, thank you Rod and all your team. Yeah. Bye bye.
Bye bye.
Bye bye.